be successful in what they're doing and what they should be doing. So as you all are very well aware, Omicron is here in our district. It is everywhere. We are seeing an intense surge of cases, unlike anything we've seen before. Delta was bad. The original COVID was bad, but in different ways. Omicron, while seeming to be less serious in the fact that it does not seem to cause as much serious illness in death, it is still very, very contagious. It is spreading quickly. And because the vaccination rates in our communities are not as high as some other areas, we are seeing a lot of sick people. And I think our hospital partners
Oh, I'm sorry. I'm not sure what happened to Amy. Let me see where she's at.
Sorry about that. Are y'all there?
Yeah, we missed you though.
That's a first. I've never been disconnected like that in the middle of one before. Okay. Sorry about that. I was saying that I think our partners, our hospital partners, are going to testify to the fact that the vaccination rates are low. The people that they're seeing in their hospitals are a large chunk of those unvaccinated. It's serious to those types of individuals. It's serious to people with underlying conditions. We don't want to take it lightly. Just because you may hear on the news that Omicron is less serious or less severe, that doesn't mean that we need to let up our guard on this. So the health department, as we said, has seen a surge of cases. There are many, many more cases than we're able to work in a day. So we have prioritized our approach on how we get these cases worked. We are looking at contact tracing only in a very limited and focused setting. So if it is a long-term care situation, an outbreak in a long-term care, an outbreak in school, daycare, congregate settings, those that are in high-risk groups, that's what we're focusing our efforts on. And then we're going to refocus our efforts, the rest of our efforts, on education, vaccination, getting people boosted as appropriately, just all the things. So the Omicron surge is part of why the health department is behind in some of our work. It is also the weather this time of year. You all know we've had snowstorms. We've had providers who haven't been able to report to work. We have had to close a couple of days this month with snow, so our own staff couldn't get in. There's just a perfect storm of the situation around all of this here the first of the year. So we're trying to dig our way out of this and get through this. So the most important thing that we can take from today's messaging is we need to educate every individual in our district on how to protect themselves, how to protect their families, what steps to take. Should you become positive or should you be around someone who is positive, you're a close contact, what do you need to do? And then how do we know when we need a booster, when we need to get vaccinated, all those things. So Dr. Wayman and Laura Woodrum, our director of nursing and our medical director, are going to speak to those. Some of our hospital staff that are joining us can also speak to those elements if they choose to. I'm very thankful to have them on here to give their perspective from things, because the health department side of things is very analytical and very data driven. We're doing the paper pushing and the paperwork of this and the education piece of this, and our hospital partners, a lot of them, they're doing vaccinations and testing and healthcare for sure of all these sick patients. So they have a very different perspective on it than the health department necessarily. So Tracy, that's enough of me talking now. So why don't you go ahead and let our partners talk to you.
I'm going to turn it over to Kevin Albert, the administrative assistant administrator. I apologize, Kevin, for the Lake Cumberland Regional Hospital, as well as Robert Parker, and he is the chief executive operator at Lake Cumberland Regional Hospital.
Thank you, Tracy, for introducing us. Yes, I'm the assistant administrator for the hospital. We have our CEO, Robert Parker, also on the line. I've just been in this role since about August of last year, but I've been with the hospital for over 20 years and part of the community. So, Robert, did you want to kick it off, or?
Yes. Can you hear me okay?
Yes, sir.
Yes.
Good,
Yes.
good. In the world of Zoom and the world of Teams, we always have to start off with that, don't we, to make sure they can hear us okay. Yeah, it's great for Kevin and I to join you and see what we can learn as well on the call today. Just to summarize, it's been, we kind of see it in terms of, a couple of waves. The wave in 2020, we didn't understand it. It was very serious. There was no vaccine, and we kind of saw that come and go. And then the wave in 2021, we had the vaccine. There was a whole new series of challenges at the hospital, particularly, we had the vaccine, but that's when the staffing challenges started, and staff, there was a lot of people that, started perhaps getting a little burnout, maybe left, retired early, and then the traveling aspect of the nature of healthcare with nurses and radiology and respiratory and whatnot happened. And so that's across the whole industry in the country. And then also, just the sheer volume of that also created that second wave. And then now we're kind of, we're still even experiencing that here at Lake Cumberland, particularly, as you guys very well know, in our region, because of the fact that we're at such a high positivity level. We've continued to be basically on diversion, if you will, which we cannot stand to be on diversion at Lake Cumberland. It's terrible. It's anathema to us to be on diversion. And what I mean by diversion is that there are times when we simply, because we have no beds, we have no staff beds, the ER is completely overwhelmed. We've got people in the lobby. We may have to inform some of our surrounding counties that we can't take some of their patients, and we cannot stand to do that. So unfortunately, we have to do that a lot we've had to do that a lot in the last couple of months. And even right now, we're on diversion for COVID in critical patients. We can take med surge levels, but we can't take COVID in critical because we have 4 ICU units, and we of course have COVID patients, and we can't support. So that's kind of kind of a nutshell. We're over 30 patients at the moment upstairs in the inpatient unit. Yesterday, we were at 40% positivity in our outpatient clinics. We've been as high as 60% in the last 2 weeks. That is patients who come into the facility to be tested for symptoms, and they think they may have COVID, So our docs will evaluate them either through telemedicine or through in person in the clinic if they come into the walk-in clinics or their offices. And again, yes, that's correct. 40 to 60% of those people have been testing positive. Yesterday, for example, I think it was 43 out of 110 that we tested in our walk-in clinic at LCMEA were tested positive. So that's kind of, in a nutshell, I guess, an overview for you. Kevin and I'll be glad to answer the best we can any questions that you might have or anything that we can offer that would be helpful.
So, Mr. Parker, if you don't mind, let me just chime in. When someone may hear that the hospital has no beds available, that doesn't necessarily mean there's not physically a bed there. It means there's probably not a staffed bed. Staffing is part of the issue there, correct?
Yes, in fact, there are several units in the facility at this very moment that we have beds available. We just don't have nurses or staff to take care of those beds. I would say, when I look at the open positions here at our hospital, in terms of nursing, for example, from a fractional perspective, the same number of openings are up in Lexington as well. We kind of talked to our colleagues in Lexington. So I know, for example, I guess I shouldn't share their number, but UK told us recently how many nursing positions they have open, and it is exactly the same fraction as you compared to the number of beds they have versus ours. So they're in the exact same position. We're seeing this particularly also in areas of radiology. Even Kevin and I were just right before this call, we were working through some issues in radiology, trying to make sure we have enough staff because we can't seem to find staff that we need. We're in desperate need, for example, for ultrasound right now. And it's just incredible. There's no ultrasound techs to be found. Kevin's looking through, he's using our contract service agency teams to try to find support there, and they're just nowhere to be found. And so as a result, that's making it incredibly difficult. When people have the rule outs we need for ultrasound in the ER, for example, and so forth, that we're having to take the techs we have and be very careful with them so we don't, wear them out, so to speak. But yeah, a lot of the cases has to do with the physical rooms not being staffed.
Mhm. I hear that from a lot of other facilities across our region and district also. Laura
Yes.
can probably talk about that too. I'll let you introduce her, Tracy. You're muted, Tracy.
I'm sorry. Now I'm going to introduce Laura Belcher. Laura is the administrator and vice president at the Medical Center in Albany.
You're muted, Laura.
Yes, thank you. Can you hear me? Thank you very much. And yes, we are experiencing the exact same thing as far as our staffing. We have beds available. We don't have staff there to take care of them. And that has been in all, not only our acute care units, but the emergency department, as well as our ancillary services. It's not just a shortage of staff, but I don't want to jinx this, but just a few weeks ago, it seems like the current variant hit our staff very hard. And it seemed like every hour we had somebody else testing positive. And so at one point, our laboratory was left with 2 employees to run it for 5 days, 24 hours.
Wow.
And we've also had the radiology department, be knocked in half as well, as far as what they are able to do with people being out. It was one day last week and I had gotten a call, and we're smaller than Lake Cumberland, and we will staff 2 RNs in the emergency department during day shift as our core staffing. And both of them tested positive as soon as they arrived at their shift, and we had no one to cover. So, those are the realities that we've been living in. And as you know, we have required the vaccination of our staff. So our folks have had the vaccination. We have not required the booster, but we are having people take advantage of that. The good thing is the change of 5 days, that people can come back 5 days earlier than they could before, as long as they're not still showing symptoms, and that their symptoms are improving if they are showing symptoms. Some have been able to come back in 5 days. Some have not been well enough to come back in 5 days. So I think that that's behind us. I think the majority of our staff have gotten COVID this go round, knock on wood. But we are experiencing about 55% of our ED volume that we've had over the last week has been due to COVID. People thinking they've got COVID, concerned about that they do have COVID, and how sick are they going to get? And they think their oxygen stats are going lower than what they feel comfortable with. So it's definitely been a surge that has hit us, along with the weather, that has created an interesting January 2022 to kick off the year.
Hey, Laura, I have a question. In your outpatient clinics, are you seeing a little bit are you seeing similar positivity rates? And because the reason I asked that question is we actually tend to detect that positivity rate is starting to decline a little bit. We've been 60, 50, 40. It seems to be coming down, which is kind of the end of the spear. Are you seeing around that level of positivity in your outpatient world, or what do you think?
We are, any of the rapid testing that we're doing, we are, as Med Center, only doing that in our ER here locally, just because of the limited supply of that. No, it looks like, as I look over the last 7 days, it looks like our positivity rate is still been up there. It seems like we've had quite a few more COVID admissions this week than what we had in the past. And I don't know if those people that just have had it, it's lingered on a little bit, and now they've realized their systems are not going to fight the virus like they had thought. But no, we've not seen the drop yet. This weekend was really, really a very, very busy weekend for us in the emergency room. And well over half of that was COVID related.
Okay.
And analytically looking at numbers, the state has said that they seem to be peaking. The state numbers seem to show that they have reached their peak. Maybe last week that may have been the highest week, and now coming down from that. But typically, that is more indicative of the metropolitan areas of the state, and the rural areas and the communities tend to be a couple of weeks behind on that type of thing. So I fully expect us to have maybe just a couple more weeks of hard times ahead of us and big numbers. And then I do hope that things do start to turn in our favor.
Very good. Thank you.
Mm-hmm.
I think the holidays for us, especially our staff, I think that created to a higher number of positivity and that virus being shared a little bit more. I think a lot of the schools in the area were on NTI for a short period of time, either due to staffing or students being out. So that helped us a little bit. But anytime we get big gatherings, I think that hurts us. And so luckily we don't have any major holidays coming up for a few months, and that might contribute to those numbers coming down.
I certainly hope so.
Hey, Amy, so it sounds like COVID is still here for a few more weeks, maybe. But Amy, you're going to share some updates that's happening for us that currently will be taking place. I'll turn it back over to you.
I am. We are refocusing our efforts. The state has sent out some guidance to us on ways to proceed moving forward during the surge and ways to keep reporting. COVID is still classified as a reportable disease. So every time there's a positive case reported or found in a provider somewhere, some office or a fast pace or an after hours clinic or a hospital or whatever, it's their duty to report that to us at the health department. And then we have to turn around and report that into all the electronic systems that count those numbers and work on all these rates and everything. So we can't stop doing that. However, we are reassessing what is effective and what is not at this point in time. And with the numbers where they are, contact tracing in general is not an effective tool at this time. It's just as a general widespread tactic. Contact tracing is very effective when incidence of disease is low. So when you have little pockets of areas, or if you have one or two cases here or there and you're trying to isolate it to that location and keep it from spreading, that's when contact tracing is useful and effective. That's how we stop those types of spreading events. When COVID is now like it is, and it's everywhere, it's in our schools, it's in our facilities, it's in our offices, it's in our workplaces, it's in our homes, our churches, it's everywhere. Contact tracing is much less beneficial on our end. It also comes from the fact that though I said COVID cases are reportable, just for various different reasons, some of which we've already mentioned with snow and lag time and whatever, reporting isn't always timely. So by the time, a lot of times that we get a COVID case, that person, by the time we contact them or reach them, that person has already reached their 5 days of time that they should be isolated and should already be doing all the things. So by the time we reach them, we're contacting them and then we're turning around and saying, well, you're released at this point. So in a lot of ways, we felt like we were beginning to spin our wheels. We weren't gaining any ground. We weren't being effective in our approach to this. So we have re-looked at it. And I'm going to share my screen and hopefully show you all, see if this will work, what we're looking at refocusing on. And this is by no means an example of us throwing in the towel or giving up on this at all. It's just refocusing our efforts and better utilizing our resources, what we can do. Hopefully you all are seeing my PowerPoint slide here. This is our bulleted list of where we're going to focus. We are looking at targeting prevention strategies and treatments to vulnerable populations. So those are those high-risk groups I've been talking about: congregate settings, schools, long-term cares, jails, homeless shelters, those types of settings where there's a vulnerable group. We are conducting outbreak investigations and targeted case investigations in those high-risk settings. And then we're going to be monitoring access to COVID-19 testing. Some of you all may have heard that this is becoming a limited resource, and it is. Some of our testing places are reporting they're having a hard time getting the tests or getting them back in a timely manner and those types of things. So we're monitoring all that, and we will look at adopting strategies if we need to address that and how we can fix it moving forward. The other part of this is we are pushing for an increase in the number of people who are up to date with their COVID-19 vaccinations, including boosters, especially for those that are at higher risk of serious outcomes. So a lot of people have went ahead and got the primary series, that's done, but they haven't been as concerned or as worried about getting that boost dose because they've heard that this new strain is not as serious, they're going to take their chances, whatever. So we do want to educate on that and explain the importance of getting those vaccinations and up to date. We're going to do strong messaging about the need for persons who test positive to self-isolate and inform their close contacts. So where we as a health department will be contacting each person individually who's a positive case, we still need them to take it serious and to notify people who they may have been in close contact with. So we have sent out letters to our providers, our partners across the region, asking them to do a little education on their end. When they have a positive person come through, just go through this with them and say, you're going to need to isolate this number of days. You're going to need to notify the people you've been around, let them know. People have been very used to the health department calling them, and that won't be the case moving forward. We won't be calling as many people moving forward on this. We're going to do strong messaging about the importance of effective mask wearing, especially during increased community transmission. So times where we're seeing high numbers of this positivity that Mr. Parker and Ms. Belcher talk about, those are times where people should be considering wearing masks. You know, we've gone through all the things before about what types of masks are recommended, and it has varied and it has changed over the course of the guidance has changed over the course of this as the strain changes. So Omicron, now they're saying a KN95 or an N95 mask in close contact, up close and personal contact with people during that time. So indoor settings. I think Dr. Wayman's going to talk some more about that, but that's the focus of the health department at this point, heavily on the education on the front end, heavily on making sure people are aware of their personal responsibility in this and how we get out of it. We cannot continue doing phone calls on these thousands and thousands of people and moving forward. So we're refocusing and putting it on the highest risk groups. That's where we're focusing our efforts and our time and education on the rest of the communities. So I think that Laura probably has more to say about that when she gets to talk. She's going to go over our guidance and our recommendations. We have a new tool on our webpage that is going to help people to be understanding of what their role is and what their isolation periods may be. So when she gets there, I'll share my screen again. You let me know, Laura. Does that concern, do you all have any concerns as to the hospital about our approach to this? Do you see anything that we need to be doing differently? Do you understand our approach on this? And
I think that's consistent with what we're trying to achieve here locally. I think the one thing that is kind of hard to figure at the hospital level is visitor policies.
mm-hmm.
You know, we can't really win on this, to be honest. You know, if we have no visitors, we get a lot of people upset. And if we have visitors, you worry about, you know, transmission, people coming in who, you know, might be, maybe shouldn't be on the floor in a hospital setting. And that's the only thing, you know, at a state level, I don't know. I know that every hospital in the state probably has different policies. Kevin stays close with sister hospitals in the state. And that is one thing we're seeing. It is kind of inconsistent, but again, that's nothing that I don't know how in the world to deal with that. I mean, every hospital's got their own approach to visitor rules, and people interpret those differently. You have people that think we're just awful, you know, for not letting them in, and they're just furious. And you have other people that can't believe we let anybody in the building. Mm-hmm. And I don't know how else to say it but that way.
We've all been going through that for years now, a couple of years now, with this on every front.
And so that's one thing that's very difficult to, that's one thing I would kind of add in the realm of what you walk through there in terms of public policies.
All right, Dr. Wayman, do you want to share with us some information about vaccine and boost vaccines?
Certainly. So, as we've been saying, I think everybody's very aware that the Omicron variant which is now circulating, is very, very, very contagious. And that's why we're having this massive surge. people who've been infected with the previous variants do not seem to be protected from the Omicron, so they're getting reinfected. The vaccine has, because it's a mismatch, has not been as effective either. However, and we've also found that the antibodies produced, or the effectiveness of the vaccine, wanes much more quickly for Omicron than it did for the other variants. However, boostering seems to bring some of that effectiveness back, not as high as we would like, but better than nothing. So getting boosters is very important. We know even currently that 75% of the people in hospital and ICU are unvaccinated or not fully vaccinated. So we know the vaccines have effect. The CDC recommends that all individuals aged 5 and up should get vaccinated. The primary series includes 2 doses of mRNA vaccine, 21 days apart for the Pfizer and 28 days apart for the Moderna, or 1 dose of J&J vaccine. Boosters should be given 5 months after the mRNA vaccines and 2 months after J&J. For those who are 12 to 18, the Pfizer vaccine is available for a booster. Anyone who's immunocompromised for any reason, either on immunosuppressive medication, chemotherapy, or post-transplant, should also receive a 3rd dose after 28 days from the primary RNA vaccines. They should also receive a booster dose 5 months later. The booster dose is now essential for any kind of protection from our vaccines. It is especially necessary for the elderly who are most vulnerable and are susceptible to severe disease. We have looked at the data from the state, and we found that Pulaski and Taylor County have vaccinated 85% of their senior citizens over the age of 65. However, Adair, Casey, McCrary, and Wayne have only managed 65%, and the other counties are in the 70%. The percent of boostering for seniors is even much, much lower, somewhere between 30 to 40% across the board. We would like everybody to get boosters if you want to be protected from Omicron. I listened to a webinar not that long ago where an ER doctor said, the Omicron may be less severe, but from what they're seeing in their emergency rooms, it looks just the same as it did with Delta and previous. So when somebody comes in to be admitted, they are just as sick as the people who had Delta. Vaccines are available in pharmacies, private medical providers, and all the health departments in our Lake Cumberland region. If I've missed out something, can somebody prompt me or ask questions?
I have 2 questions, really, Dr. Wayman. Has there been any guidance on when you should receive a booster given natural immunity? Because there's a lot of folks that had COVID, they were vaxxed. I mean, I'm one of them, by the way. I was fully vaxxed and got COVID last year, and so I'm wondering, you know, is there data on when I should be boosted or not? Do you know?
Well,
I'm just personally, but quite frankly, I do get that question a lot from people who've had COVID, and they say, "Well, what about natural immunity? Is there any data whatsoever on when I should be boosted?"
So it's a complicated question, and there is no recommendation. But if you were infected with the old variants, then you probably have not very much immunity against the Omicron. So you should get boosted. If you were infected with the Omicron, then you probably have quite a lot of immunity against the Omicron. So people who are getting the infection now in the last month, I think can wait for a booster. because now their antibodies are up and they're probably specific for Omicron. So if they want a booster, me personally, I would wait a little bit. If they were infected a long time ago, it wasn't Omicron, it was something else, and they should be boosted according to the recommendations.
Okay, thank you.
Does that answer your question?
Yes, and it's a little confusing because there have been publications and stories about how Omicron, how the boosters are ineffective against Omicron. I mean, just to be honest, I've seen some of that, so I don't know. Sometimes it is a little confusing about whether the boosters are working against Omicron at all.
Well, the data I've seen for antibodies against Omicron on a booster are much better than no booster.
Excellent.
So no, it's
Okay.
not 100%, but it's, 60, 70%.
Excellent, thank you.
So,
And then-
I mean, I think it's worth it.
And the second question I get a lot is, when does anybody know, or I'm sure I'm asking you, you probably don't know unless you have an inside track here, but does anybody know anything about FDA approval for the Moderna?
I
And
thought
have you
they
heard
just
anything?
approved it. I thought they gave that full approval just,
I think it was just
I read
earlier
it.
this week. And they changed that, they're gonna market it now under the trade name Spikevax or something, so.
What was that, Amy? I'm sorry.
Let me turn my sound up so you can hear me better. I said, I think they just approved that earlier this week. And it's
Oh,
now
is
gonna
this-
be marketed under Spikevax is gonna be the name of it moving forward instead of Moderna. So
Okay.
it's, yeah, it has been approved. I'm fairly certain. I can double
Yeah.
check that for you.
I haven't heard that. That's good news. I did not know that. So that would answer that question. Thank you.
I would say too, and I totally trust Dr. Wayman's opinion on medical advice. I go to her all the time for things, but as far as your question about when you should be boosted, you may want to talk to your own private provider about that, because there could be underlying conditions too, that's at play there. So.
Yeah.
Just as a
one thing
disclaimer.
I'm waiting for is to see if the CDC changes the 5 months.
Hmm.
Mhm.
Because as the data I've seen, that the antibodies wane. Now, of course, I'm not talking about the T cell response, that seems to be more resilient, but the antibody response really dramatically drops for Omicron. So they may change the 5 months to 3 months. I don't know.
Okay. Very good. Thank you.
Okay, any other questions for Dr. Wyman? Then Laura Woodrum, I'm going to let you speak now if you don't care to share about the updates that we're doing within the health department.
Sure. I wanted to talk about contact tracing and the recommendations for quarantine and isolation. If Amy will share that screen, please.
Let me figure out where it's at on here.
So as Amy mentioned earlier, we aren't calling, health department staff aren't calling all of the positive labs that we receive. There's just no way to keep up with the surge. That's not as, oh, wow. Can you all still hear me?
Yes.
Okay, I got a message that said Zoom has done something.
You're still good. Now you seem to be frozen, Laura. No, she got kicked off.
I think now she's on.
Laura.
I think I'm back. Am I back?
You're back. I can hear
Yes.
you. Yes, there you are.
Before, you all, I don't know what happened. Zoom's been funny today. It's got a sense of humor, I guess. So the guidance, if you have symptoms and you have tested positive for COVID, you should isolate for 10 days from the date that symptoms first began. So if symptoms do fully resolve or are resolved by day 5, you can return to normal activities. But it's recommended you wear a face mask for at least 10 days since the beginning of symptoms. And for workplaces and whatnot, isolation should not be shortened if a mask cannot be worn properly. If you have never had symptoms and you test positive for COVID, you can isolate for 5 days from the date that your test was done and wear a mask for 5 additional days. If you were to develop symptoms during that time, you would need to look at extending that to 10 days. If you're not up to date on your COVID vaccination and you've been in close contact with someone that's been diagnosed with COVID-19, 10 days from your last exposure is what's recommended for you to quarantine. Quarantine may be shortened to 5 days if you don't have symptoms at the end of those 5 days and you have a negative test. It's also recommended that you wear a face mask for 10 days. If you were to develop symptoms during that time, you need to get a test if possible. Now, for folks that are up to date on their COVID vaccinations, that means they've had their primary series and it's time for their booster and they have received that. If you're in close contact with someone with COVID-19, you don't have to quarantine as long as you don't have symptoms, and you do need to wear a face mask, and it's recommended to get tested on day 5 just to verify that you are negative. So that's the recommendations. Those are found on our website. Those are also found on the Kentucky COVID website. Most of the latest guidance on all types of subjects is on our website, which is lcdhd.org. And there's several different links that can be chosen there and get some different information. So I was
The question about 5-day quarantine and shortening the quarantine, that's 5 days if you're asymptomatic, first of all, you don't have symptoms at all, or if you've never had symptoms, or as long as your symptoms are improving and you're fever free, correct?
resolving. Yes.
Resolving.
Improving.
You're having improvements. Okay.
Yes, that's correct.
And that's the majority of people. By day 5, if you're symptomatic, most of the time people are improving at that point, correct?
That's what we generally see.
Okay.
So a new thing that we are seeing is we're getting a lot of questions about at-home testing as those become more available. At-home tests are not reportable to the health department. We don't need, we don't need to know if you had an at-home test that's positive, but we do recommend that you follow those guidelines that I just talked about, and those are on our website as well. We've also got a calculator that people can use, and I think Amy was going to share that. We've just been able to get that developed this week. So if you go to our webpage and you click on, have you tested positive or been exposed to COVID-19? You can click on that. And then scroll down, and the first thing you see is the calculators. So let's say I have tested positive for COVID-19. And it just gives you some instructions there to stay home and how long you should stay home or wear a mask. And then if you click on the date that your symptoms started, you can do that and hit calculate, and it will give you instructions. So we hope that the public will use this calculator, and they can also use it for if they need a work letter that they can't obtain from their physician or their lab provider. They could use this, or the workplaces could even use this if they're trying to calculate and figure out when someone could come back to work or to school. So it has a feature at the top of this page where you can print if you'd like to print this page to have. But we're excited to have this to help the public figure out these dates, and because sometimes the guidance is just a little bit confusing. So, and it changes often too, and we understand that. So the health department, in saying that, the health department is no longer providing letters to folks that test positive or have been exposed for the purpose of exclusion from work or school or just release from quarantine. So if you do need a copy of your lab, you can get that from the provider that did your test. And to help you know what your release date will be, use the calculator we just demonstrated on the website, and also print that out if needed.
So that calculator tool, I hope will be very useful for people when they get a positive test. They can take their results and that letter that they can produce then from that webpage that shows their isolation period and quarantine period. And that should be sufficient for employers or schools or whoever needs documentation of their illness. The letter alone from us may not be enough to get you what you need for your schools, but if you have your positive lab also, the two of those together should count for whatever documentation people need moving forward. And I hope that tool will be useful for everyone, and it will be a much more timely process than us trying to go through all these cases and work these letters and get things out to the public. Tracy, do we have any specific questions that we need to address? I think we've all kind of gone over our main points.
I think you've answered most all the questions, Amy, as I've reviewed some. I do not see any that's came in on YouTube either.
Okay.
But I do want to say, you might want to summarize just again, there's some great new tools out there on the website for people to access and use. So you might want to summarize some of the main points from what you all have talked about over the last few minutes.
Okay, I will be happy to. We are at the health department. We're going away from a daily report. First of all, I don't know that we've mentioned that or stressed it heavily during this call, but last night was actually the first night that we didn't do a local daily report. And that is, as I said earlier, due to the fact that our case log is so far behind, our numbers are not reliable locally. They're much more reliable at the state level. So we are sharing that data to keep confusion down rather than try to report our numbers and their numbers and them be vastly different. It's much simpler at this point to go with the state numbers. And the state has streamlined processes and sped up reporting criteria and processes, and it's a much more reliable number now than it was at the beginning of the pandemic. If you all followed us on these briefs early on, a lot of times we recommended using our local data because it was more up to date than the state data because of their backlog. Well, they have fixed those issues and those problems on their end, and now their data seems to be a better figure for us to work on at this point than ours locally. So we're daily sending out that state report to everyone. Last night was the first time we did that. I went through the state report and highlighted in yellow yesterday all of our local counties, so you would see it and it would stand out on the document for you until you get used to seeing it. So for the first week or so, I will keep doing that until you learn where the figures and the data that you're looking for are at. A lot of those data pieces that are on the state report were things I was using in our local report anyway. I was just pulling it out for you and giving it to you. So this kind of cuts down on that middle process. So that is changing for us. Moving forward, the health department will not necessarily be calling every positive case. We will target to congregate settings and high-risk groups. And then we are refocusing on education and vaccination efforts and some of those things that we went over. To assist with that, our website is being reworked and making sure that all of the most current up-to-date guidance is there for you all to use as resources and to have available to you. We've also deployed, as of today, this morning, our calculator feature went live so that you all can use that as a tool to put in your date you became symptomatic or you tested positive or you were last exposed, and help you to figure out what would be the day that I can move forward and feel safe about going back to school, rejoining the workforce, whatever that needs to be. There's also a print feature on that, so you can print that document You could screenshot it, whatever you need to do to use it for documentation purposes. Did I miss anything? Of course, we encourage vaccination boosts. If you haven't been boosted yet, get your boost. It is readily available at all sorts of providers around our district, private providers, pharmacies, health departments, grocery stores, just anywhere and everywhere you can get a vaccine. They are not at all limited like they were early on in this, and we encourage vaccination.
Okay, thank you, Amy. I think you covered most of those points. But in saying that, Laura, Mr. Parker, Mr. Albert, is there something you want to share as a final comment or thought?
I think we're good, and we appreciate the opportunity to participate today.
Yeah, thank you very much.
Thank you. I don't have anything else other than please use the resources that are being provided to you as the members of the public to make sure you're doing your part to help us curb COVID spread throughout our communities.
Very well said, Laura, as we go off. And thank you all for joining us.
Thank you all.
Thank you.
Thanks, everyone.
Thank you all.
Bye.
Bye-bye.